program that we have on East 59th Street and 2nd Avenue on the 2nd floor, where we have pain management, rehab medicine, spine surgeons, and also access to neurology, complementary medicine, and cognitive behavioral therapy. This is part of our conference that we've started 2 years ago in the start of the pandemic, to provide basic information and questions where you can chime in at any point. So you can use the chat to answer a question, and I'll do my best to be able to get an answer for you. If we run out of time, we also encourage you to make an appointment, and I'll give you the number at the end. This video is being recorded and will be available along with past sessions on our YouTube channel. Finally, I ask that your questions be more general and not so specific to you, as it will help more people to be able to provide the answer. With that, I'd like to introduce our panelists. Dr. Daniel Pack, he's our pain medicine specialist here at Weill Cornell Medicine, and he's an assistant professor in anesthesiology and one of our fellowship directors. Dr. Srikanth Boddu is an interventional neuroradiologist in the Department of Neurosurgery, both here at the Weill Cornell main campus and NewYork-Presbyterian Queens. And Dr. Justin Schwarz, who's an assistant professor of neurological surgery and also a specialist here in spine and vertebral fractures. So welcome, gentlemen. Thank you for coming along, and I think you're going to really enjoy talking with our patients about vertebral fractures. So first, Dan, I'd like to ask you to give us a little background. Talk to us about what is a vertebral compression fracture.
Sure. So, I'm happy to be talking about this subject just because we do see a lot of these patients in our clinic. Vertebral compression fractures are just like they sound. It's a collapse of the vertebrae in the spine, and unlike fractures of, let's say, the arm and the leg, where sometimes the bone will splint off, in this particular case, you actually have a collapse of the bone. Now, it's a pretty pervasive problem. It certainly affects a lot of our patients, but most commonly in a lot of our patients who are elderly, so specifically postmenopausal women, and particularly patients over the age of 80, can occur up to 40% of women after the age of 80. And that's oftentimes because of things like osteoporosis, which you may have heard or may already have been diagnosed with, but basically the bones are brittle and soft, and as a result, can oftentimes put you at risk for something like a compression fracture. We can certainly talk more about symptoms and diagnoses and all of that,
Sure.
but kind of the most common symptom that we see for patients after something like at least an acute vertebral compression fracture is something like really severe pain. But severe pain that can oftentimes also really affect different things like activities of daily living. So really difficulty walking, standing for prolonged periods of time, et cetera.
Got it. Talk to us about some of the risk factors for this.
Osteoporosis is perhaps the most common cause. You can get fractures, unfortunately, with very simple and otherwise non-provocative tasks, like something like lifting a light object. I had a patient, even after a heavy sneeze, had a compression fracture afterwards. But patients with healthy spines can also sustain compression fractures too. And this is oftentimes after, let's say, some kind of severe trauma, like a car accident, sports injury, or even a hard fall. Now, if we're continuing on beyond that, patients with cancer where the disease can actually metastasize to the spine and can weaken the integrity of the bone, can also cause a collapse of the fracture. And unfortunately, patients with a history of vertebral compression fractures in the past are at up to 5 times higher risk of sustaining an additional fracture after that. So those are usually the most common causes that we see.
Got it. And I know you've talked a little bit about symptoms. Walk us through some of the things that are really classic for this type of fracture.
Sure. So, the one thing I want to mention is that there's acute compression fractures and there's also chronic compression fractures. Patients with chronic compression fractures oftentimes don't have any symptoms at all. So we will often get x-rays in a patient and they have what looks like an old compression fracture, and the patient will say that they were never symptomatic from it. So chronic compression fractures can not present with anything. Now, acute compression fractures most commonly present with back pain at the area of where the fracture is. Now, in addition to that, many patients will say that it's particularly painful with changes in position, prolonged sitting, ambulating for prolonged periods of time. Also, there are other things that can present. So if you have pain radiating across the chest, down the legs, that may be a result of some type of involvement or maybe compromise of the nerve elements in the spine as well. That's a little bit less the case with mild compression fractures, but if you have a severe compression fracture, those things can present. And other things like numbness, weakness of the lower extremities, we also oftentimes see. If the fracture is extensive, then you may actually see height deformity too. And I'm sure some of my other colleagues can talk more about that later.
Sri, Dan talked a little bit about acute versus chronic. What sort of timeline do you think about that? And what's your sort of evidence to determine if it's old versus new? Sri, were you able to hear me?
Sorry, I was muted. So the timeline, it is variable depending on the age of the patient and the bone quality and the underlying edema. MRI is the modality of choice to understand if the fracture is still acute or chronic. One of the pitfalls from the very early trials is that they were selecting the patients based on the CAT scan or just the plain films, not knowing whether this is an acute fracture or chronic fracture. So the best way is to identify on the MRI to see if still there is an edema, which means a patient that correlates with the patient pain, and treat those patients accordingly. And normally it is the 4 to 6 weeks time is an ideal one to see if the edema is there, and that categorizes as an acute fracture, beyond which once the edema subsides, then it becomes a chronic one.
Got it. Justin, you see a lot of these patients in the hospital. I know you do too, Sri. How do you determine whether you're going to take action in the hospital if they come in through the emergency room and get admitted? And how do you decide whether to treat it at a future visit?
So I think it all depends on the degree of pain. I think that certainly the first step is, they're causing you to have, if the vertebral compression fracture is causing you to have pain that's relatively well controlled with oral medications, that's something that we can deal with on an outpatient basis. But we certainly have a good percentage of patients who come in with acute compression fractures who have a really hard time either tolerating medication, so the pain medication they may not be able to take it for some of the side effects, or despite pain medications, it's still really intolerable to ambulate. So those are patients that we typically get admitted to the hospital for pain control, and then we consider to do a more expedited workup and kyphoplasty or procedure for.
Got it. Thank you. Dan, what sort of medications do you generally recommend for patients to sort of get through this? And I guess, as Justin mentioned, that's a factor in determining whether to go on to an interventional procedure.
Right. I mean, we always try to manage these conservatively, and certainly initially with acute pain, we will use a variety of different types of non-opioid and opioid analgesics. So it starts with things as simple as Tylenol and also non-steroidal anti-inflammatory medications, maybe even muscle relaxants, if that seems to be a component of the pain in terms of muscle pain. If that really isn't helping, then then we consider things like low potency opioids. So these are your other kind of classic pain medications that we consider. Now, I think to Dr. Schwartz's point, there are many of our patients, especially elderly patients, who can't really tolerate those medications. So as many of you are aware, opioid pain medications can work for this type of pain, but it comes with a lot of other issues like constipation, nausea, a lot of other cognitive issues. And so for those patients, then if they can't really tolerate them, then we start thinking about maybe we should offer intervention instead.
And I know on this slide, we talk about braces. I opened this to the group. what specific brace are we recommending? How do you determine the brace? Where do they access it? Where do they get it? And how do they use it?
I mean, the two common forms of the braces we are using is the TLSO for the thoracic fractures and the lumbar corset for the lumbar fractures. But yes, I agree with the patient. Most of the common patient complaints, it is a nightmare to put those braces on, especially the TLSO brace for the upper thoracic fractures. And one of my concerns in the day-to-day practice is the eventually, especially this is seen in patients who decide to go for the conservative management and the saying of the brace for 3 months and then you will be fine. A couple of my issues with that one is by the time you take off the brace in 3 months, your paraspinal muscles are in general weaker because we are blessed with the erect posture compared to the other animals because our paraspinal muscles are like a bowstring. They hold you tight back.
So I'm going to interrupt you for 1 second, Sri. Maybe you can just explain what is a paraspinal muscle?
Oh, the two thick band of muscles we have on either side of our spine. So those two muscles will hold us like a bowstring and keep us erect because these muscles run all the way from the below our head all the way to our bottom. When we are using the brace for a long term, the brace is doing the job of these paraspinal, muscles. And it's a sort of a disuse atrophy. You don't use these muscles as often as you have to. So slowly they become more softer. And eventually when you take the brace off, you don't have enough strength and you start to see the patients leaning forward. That is one concern. But it is other than that, but definitely I agree they provide some element of pain relief in the acute phase for these patients.
And how often are they supposed to wear it? I mean, when I see patients no one enjoys wearing it. Yes. They often are wearing it just an hour or two a day, and others get more nervous and wear it even when they sleep. So I'm curious how you guide people.
At least in the beginning, I would tell them it is I mean, I'm a more interventional candidate, so till they have their fracture secured, I want them to wear it as long as they can, but they don't need to wear it during the sleep. But there are patients, depending on the pain severity or intensity, they even wear, especially the lumbar fractures. They feel the pain when they are twisting and turning in the bed, they continue to wear it. I think wearing the lumbar brace is relatively more comfortable even during the sleep compared to the TLSO upper brace.
Got it. Okay. In terms of physical therapy, how do you guide people with physical therapy? When is it safe to do it, and when is it actually contraindicated for anybody in the group today?
I mean, I think there's always some activity limitations that we try to advise patients. So specifically, I will say avoiding heavy lifting, a lot of extensive movement at the spine. So a lot of flexion extension movements. I usually discourage patients from doing that. But I think to Dr. Boddu's point, you don't want them to be inactive because that essentially causes weakness of the core strength and of the core, and also you need to be able to continue to activate those muscles. And so I think PT is something with some limitations. Oftentimes I will encourage, specifically more for kind of the core strengthening element and also maintaining just their mobility in general. But there's always some limitations that I at least specifically will tell patients not to do. So like heavy lifting, et cetera.
Okay. I know we're about to talk a little bit about the procedures of vertebroplasty, but maybe Justin, you can walk us through a time where surgery is actually indicated. Maybe share with us that.
Yeah, so certainly vertebral compression fractures can be so severe that they cause compression of some of the neural elements. So in the spine, the spinal cord is right behind the vertebral bodies. So you can certainly have compression of the spinal cord. or a lower down of the nerves in the lumbar spine, which could either cause weakness, numbness, or significant lower extremity symptoms, where the main thing would be that we would need to relieve the compression of the nerves in the spinal cord. So those are really the most severe situations where we would certainly I think surgery would be more indicated, because we would have to physically remove the compression of the nerves, as opposed to just dealing with the pain from the fracture of the bone itself.
Thank you. Now we've talked about thoracic and lumbar fractures. Help me understand the difference between cervical fractures and the rest. How do you change your approach, if any?
Cervical fractures. So it is the thoracic fractures, the cervical fractures, or these are the fractures in the neck, and the up to thoracic levels. It is up to the first two of the thoracic. So we all have the 7 vertebral bodies in the neck, and 12 in the upper back, which we call as a thoracic, and 5 in the lower back, which we call as a lumbar. Strictly speaking, the fractures in the neck, or the 7 cervical vertebral bodies and the first 2 thoracic vertebral bodies, are not accessible for kyphoplasty. Yes, it is in the rare occasions. Yes, we can be really aggressive, but it is risky. I would safely defer them to the open surgical approaches. And anything from T3 below, all the way down to the entire thoracic spine and the lumbar spine and sacrum, they can be intervened with either it's a kyphoplasty or vertebroplasty, as long as there is no underlying cord compression or the nerve root impingements.
Got it. Thank you. Just so that we continue to engage with our audience, there's been a couple of questions on pars fractures, and I know it's slightly different than what we're talking about here, but for our panelists here, how would you approach pars defect fractures in terms of treatment and from conservative to later on? And maybe you, Justin, that takes this one.
Yeah, Justin.
Sure.
Justin.
Yeah, so there's a bunch of different types of pars fractures or pars defects. Certainly, probably most of them that we see as everyone gets older are related to degenerative changes. And certainly they can be a significant cause of pain because it takes away sort of a stability element of the bony spine. So certainly, the most common thing I think would be pain with motion, and potentially that can cause, certainly some compression of the nerves that exit at that same level, which could result in pain down the leg or radicular pain. Typically, if they do happen, it's in a more mobile area of the spine, which would be the lower spine or lumbar spine. And I think it depends on the symptoms. So there's a wide variety of treatments in terms of how how to really deal with it. Certainly the most conservative way to deal with them first would be things that take sort of pressure off the spine and strengthen the core, which can significantly help for some people who are having back pain from that. So things like weight loss, building up the core strength, certainly can help a lot of people get some longevity and improve their symptoms. But for people who have persistent pain despite that, severe pain or radicular pain down the leg, it certainly would be a candidate for surgery. But the reasons for those fractures and sort of the symptoms that you're having kind of have to be tailored to each person. So you would really need to see a provider to sort of go through what the best treatments options are. But certainly pain from a chronic pars fracture or pars defect can be addressed surgically. Great,
thank you very much. All right, so let's talk a little bit about sort of the morbidity and risks with this, but I actually want to make sure we get time to talk about the treatment. Maybe we'll start with this, treatments of fractures with this term vertebral augmentation. Walk us through this. I think Sri, this was your slide?
Sure, yeah.
Yeah.
So am I supposed to see the slide or it is not?
Sorry, I don't know if it's still sharing or not, but let me see here. It was your slide on kyphoplasty versus vertebral
Yes.
plasty.
So the vertebral augmentation is a generic term used for two different approaches. One is kyphoplasty and another one is called vertebroplasty. Depending on where it is being done, the end result or the aim of both the procedures is the same. Suppose if you are getting it done in Europe, the vertebroplasty is more common. And whereas in US, it is a kyphoplasty is more common. Either it is for the insurance purposes or the way you are trained, and that is the most of the way that is split. It is seen. The main difference between them is the in terms of the kyphoplasty or vertebroplasty, the underlying theme is you will be doing the height restoration. So you will put a needles into the fracture and you will use a balloon through the needle to restore the height of the vertebral body which was fractured. So in case of a kyphoplasty, you use the balloons to restore the height, whereas in vertebroplasty, you don't use the balloons. You are just injecting the cement. When the studies were tried to compare kyphoplasty versus vertebroplasty, because you are creating a cavity using the balloon, your risk of a cement leaking out is far less in kyphoplasty compared to vertebroplasty.
Your attention, please. Your attention, please.
Sorry.
Trauma team Delta to the emergency room. Trauma team Delta to the emergency room. Your attention, please. Trauma team Delta to the emergency room.
Sorry. So it is in terms of that height restoration, it is achieved by both, but the risks of a cement leak is much less with kyphoplasty compared to the vertebroplasty.
I see. And Dan, I know you and I have talked about some of the innovation in this, and tell me what is on the horizon or sort of new in this space for augmentation.
Sure. So, I won't name specifics or won't talk about specific products, but certainly what has traditionally been done again is the vertebroplasty and the kyphoplasty. Now, there are different types of implantable therapies that have come out on the market recently to specifically try to restore the height. So instead of using a balloon, for example, there are some folks out there in a specific company that actually will place an implant that can mechanically, just like a car jack, will kind of lift the vertebral body up. So you can actually restore the height that way. There's also a lot in terms of different ways of getting access to the vertebral body. And so there's a lot of certainly innovation in that space. But just like anything else, patient selection is by far the most important. So there's certainly not a one size fits all type of treatment out there.
Sri, I think this is your slide. Let's walk through the technique for it. How do you do it? What's the anesthesia and what's the recovery like?
So these are kyphoplasty. Almost always, it is at least in my experience, it is 90% of the times, 98% of the time, this is done as an outpatient procedure under conscious sedation, which means we are using something like a colonoscopy sedation. You are in a twilight and you are not put to sleep or general anesthesia, endotracheal intubation. No, that is not works. These are particularly tailored for the elderly patients and who has other comorbidities. So in order to do it in a minimally invasive fashion, these are designed. So this is the anesthesia wise, this is a twilight sedation, and they will be positioned prone. And yes, we know patients who have the pain even to turn. So in those patients, anesthetist will help them to give some sedation, and then we will help to turn the patient. They will be lying on their tummy, and you will make a 1 to 2 millimeter nick, which does not even need any stitches, and needle goes through those cut into the vertebral body, and everything is done under the X-ray guidance. Typically, you have a couple of cameras, one on top and one on side, so you will be seeing in two different planes every movement you are making. And the needles go into the fracture line, and through the needles you will use the balloons to restore the height of the vertebral body. And once the height is restored, you will take off the balloon and you start to inject the bone cement, which is the composition of a healthy adult bone, which is scientifically called as PMMA. It is a polymethyl methacrylate. And once the cement is injected, you have maximum like a 15 minutes duration. And after the 15 minutes, it becomes like a rock. And if you actually throw that at someone after it is dried up beyond 15 minutes, you can hurt them. So it is like by the time you finish the procedure, like a typical time frame wise to do a single level kyphoplasty, it takes you somewhere like 20 to 25 minutes. And by the time patient is out of the room, the bone is already rock solid. And patient feels a different type of pain that is because of the needle going through the skin and muscles. And most of the times patient should not require anything more than Tylenol. So once the procedure is done, patient is turned to his back and goes to the recovery. And we will keep the patient in recovery for 3 hours and they go home on the same day. We will all ask the patient to take few steps, go to the bathroom, and then they go out of the hospital. And the typical wise, I tell the patients, stay in the bed as much as they can on that day. They can, of course, they can go to the bathroom, go to the dining and these things. But next day, I want them to take the dressings off, take shower, and they can walk around in the house. And day after, they are off the radar. They can go out.
Great. Dan, how do you counsel patients about risks? Like what kinds of things are expected? What are things that could go wrong that patients should know about?
Sure. I mean, just like anything else, it's always a risk-benefit analysis of the procedure itself. Now, the vertebral augmentation procedures in general are very safe, as Dr. Boddu talked about. And I think he did a great job of kind of walking through the steps. But it's from a procedure standpoint pretty minimally invasive. Everything is done under X-ray guidance, and we always know at every point during the procedure exactly where our needles are and where our instruments are. Now, having said that, there's always some other things that we talk through patients, and any single time we do a procedure in the spine, there's always a risk of bleeding, infection. People will ask about things like nerve injury or spinal cord injury. I will usually tell patients, of course, that's a possibility, but I would say pretty remote given the fact that the procedure is done completely under X-ray guidance. So like I mentioned, we always know where our instruments are at any given point in time. In addition to that, patients should also be aware that there's always a risk of, although the bone cement should be well localized and contained within the vertebral body itself, there's always a risk of that potentially leaking. And so if it gets into, for example, blood vessels, it can cause emboli, or basically clots in the blood that can be problematic. Now, that's always, there's always a possibility that something like that occurs, although extraordinarily rare. And again, while we do the procedure, we do it under live fluoro, especially when we're releasing the cement. So we know exactly where the cement is, that it's being contained. It dries up very quickly. And if it does get into the blood vessels, we are always aware of that. And so I would say, generally speaking, these are all things that patients are counseled upon, and it's up to them to kind of make a decision about, do the benefits outweigh the risk, which I think for many patients it does.
Sure. I know we have a few minutes left. One of the things that I have seen in the last few months, I've had a number of young women who are pregnant develop sacral fractures and vertebral fractures. And maybe one of you can sort of walk me through why that's happening and how do you treat it?
I mean, it is the young patients. It is the probably if you are saying the vertebral fractures, I presume those are more likely in the lumbar region and the
Correct.
sacral. Of course, it is.
So I've had 3 young women with sacral fractures. That one had twins, was expecting twins, was 35 weeks. Another one with L5 fracture. Just, and curious what was happening. But, even if they're an elder patient, what's happening here?
Yeah, I mean, it is the sacral fractures or the vertebral fractures. The commonest cause is osteoporosis. I mean, it is the more than once, if you look at the population more than 60 years, 1 out of 3 patients will have a vertebral fracture in their lifetime. Or if you look at more than 80 years, every alternate person will have a fracture in their lifetime. So that common it is. And especially when it comes to the sacral fractures, it is even though we know about the vertebral fracture for a long time, the first ever sacral fracture was reported only 40 years ago, and first intervention done around 20 years time frame. So it is pretty new, even fairly new compared to the vertebral fracture treatments. We can fix the sacral fractures in the same way as vertebral fractures, and we call that process as a sacroplasty. We are using the cement to fix the sacral fractures. And again, osteoporosis is the common one, but unlike the vertebral fractures, the sacral fractures does not even need any trauma to happen. Your weight itself acts as a trivial, it's enough to cause a sacral fracture. That is proven because patients in long-term bedridden status, on the bed rest state, they are very, very prone for the fractures, and especially the sacral fractures. And on top, patients with a chronic arthritis, like a rheumatoid arthritis, or who are on steroids, long-term steroids, and they are very prone to have the sacral fractures. And unfortunately, unlike the vertebral fractures, it is very difficult to diagnose the sacral fractures because X-rays or the plain films are pretty useless to diagnose the sacral fracture. And even the CT, you need to look at them with a very high index of suspicion. But whereas the MRI is your gold standard, it will show you the edema, and or the bone scan, which will show you like a classic H-shaped sign to show which is a sacral insufficiency fractures. So it is the diagnosing these fractures is the key in sacral insufficiency. There was a study that showed in patients with more than above 55-year-old, and who comes in for the low back pain, almost 2% of them have a sacral insufficiency fractures that were not diagnosed or detected on a routine imaging.
Okay, well, I think we, I apologize. I didn't realize that I wasn't sharing the slides. This whole time I thought I was, and I'm sorry about that. We have one last question here. I guess there's a couple of questions about fusion surgery, which is a little different than what we talked about today, but since we have our esteemed panel, what is the time frame for how long a cervical fusion can last before potentially they have to go to another level, and what do they consider with that? I know that's a sort of a broad question, but Justin, being the surgeon, any thoughts there?
Yes, so certainly, everyone's spine is different for sure. And I think that the main thing is, we certainly do a lot of work to make sure that we do the right surgery from the get-go. Certainly, after a fusion, there is a risk of having some what we call adjacent level disease or disease that's right next to where the fusion mass is, because it sort of creates a lever arm and puts more pressure on the level above and below the fusion. We do everything that we can in the surgery that we do to sort of minimize that risk. So, it's hard to give you an exact, exact number, but, certainly our goal is so that, whatever cervical fusion or whatever fusion we do is long lasting. But certainly there is a small risk of worsening disease both above and below the level of the fusion. And again, I think that, all of these things are